Thank you for joining iMeet. When you hear the tone, you will be the 9th person to join the meeting. This meeting is now being recorded.
Good evening, everyone, and welcome to our monthly AABIP webinar series. I'm Ara Krishnan, coming to you from Loma Linda University, and on behalf of my co-moderator, Dr. David Shah from Harbor UCLA, we're again excited to bring you another highly anticipated presentation. Today, we actually have two speakers for the admission price of one, and they're going to discuss what I consider a very important topic that really impacts us frequently in our daily interventional practice. But before formal introductions, I'd like to review a few housekeeping matters. First, everyone, please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website, and this can be found under the Education tab on the front page. Second, we ask that all participants mute their phones during the course of the webinar to minimize background noise and, of course, optimize the overall listening experience for the audience. Alternatively, you can use the volume control icon at the bottom right of your iMeet window. Now, to ask questions or communicate with the group during the webinar, please type them into the chat box. This can be accessed by clicking on that little thought bubble icon located in the bottom left of the iMeet window. We will keep track of these questions as they come up and address them toward the end of the hour in a formal Q&A period. So feel free to type in your questions at any time during the hour. And finally, a couple important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So without further delay, I'd like to turn things over to Dr. Shah for our formal introductions today. Dave?
Thanks, Ara. And as Ara has mentioned, today we are really fortunate to have two experts join us. Their topic is going to be anesthesia considerations for rigid bronchoscopy. We have two individuals coming from Cleveland Clinic. One is Dr. Sonali Sethi, who is the Assistant Program Director for Procedural Training and an interventional pulmonologist. We are also lucky to have Dr. Basem Abdelmalak joining us as well. He is a professor of anesthesiology and the director of anesthesia for bronchoscopic surgery, which is obviously absolutely pertinent to our discussion today. So I really appreciate both of you joining us today, and we'll turn the floor over to both of you.
Thank you, David.
Thanks, David. Thank you all for joining us this evening. We always start with the conflict of interest disclosure. I do receive a small royalty from the sales of these two books in front of you on the screen, in which there are a couple of chapters talk about some of the issues that we're going to be discussing today. Dr. Sethi and I also put out a couple of examples of articles that discuss this topic. Many of them are from our group, as you could see there, and some from the group at MD Anderson. This would work as good reference if you need additional details of what we will be discussing today. Dr. Sethi?
Sure. I'm going to start by going over the objectives of today's talk. At the end of this presentation, our hope is that you're going to be able to discuss what a modern, fully equipped bronchoscopy suite looks like, traditional airway management options for rigid bronchoscopy, and we're going to give you a bunch of takeaway clinical pearls or words of wisdom in airway management for rigid bronchoscopy. So we're going to start out with a clinical case. I'm going to present this case to Basem, and then we're going to have a conversation kind of like we do in our bronch suite when these patients, difficult patients, come into us. So Basem, I have a 72-year-old female former smoker here who came in from an outside hospital for shortness of breath and a productive cough. The symptoms started about 6 weeks ago. She was found to be a new onset AFib, and for that she was started on apixaban and amiodarone. She's on both of those drugs right now. This is what our chest x-ray looks like. As you can see, there's a widened mediastinum here. And when you look at CAT scan images, you can see that there's a mediastinal mass that's starting in the upper to mid-trachea. And as we go down on further cuts, you can see it's now starting to compress on the trachea itself. There's also compression of the SVC, and the mass continues to compress on the proximal main stem bronchi here. As you can see on the images here. She was transferred in to the Cleveland Clinic for this large mediastinal hilar mass compressing on the trachea and proximal mainstem bronchi, obstructing the posterior right upper lobe and apical segmental pulmonary arteries. And as I mentioned, there's compression on the SDC. She is having stridor. She is complaining of difficulty breathing. There is some orthopnea. And like I told you, she was put on apixaban. She's on that now, and she's on some other medications here for her diabetes. So when I ran up to see her, Basem, she's like 99% on a couple liters, nasal cannula, coags look okay. Rest of her vitals are okay, but she does have stridor and wheezing bilaterally. So I can tell you from my standpoint what I need. I need to put in a rigid bronch. I need to get a diagnosis, and I need to place some kind of Y stent. So most of you guys are well familiar with this, but you need to be very familiar with your rigid bronchoscopy equipment. There are various sized telescopes and bronchoscopes that are out there. They vary in size, actually anywhere from 26 centimeters to 45 centimeters in length, 8 to 18 millimeter diameter. Tracheal scope is generally the Brian Dumont system, which we have. The tracheal scope is 26 centimeters in length. The bronchial scope is 38. The bronchial scope itself has a series of holes at the distal end, as we know, that allows for ventilation of the opposite lung when the scope is placed into the mainstem bronchus. There are various sized telescopes that go in through these rigid scopes, and as well as there's ancillary equipment that needs to fit in through these scopes as well. The general indications, and we're going to go through a couple of these cases, so you're all very familiar with this, but we're going to present some of these situations so that we can understand the anesthesia that's involved with each of these. But the general indications are for foreign body removal, tracheobronchial stenosis and dilation, tracheobronchomalacia, patients who have hemoptysis need clot removal, malignant central airway obstruction, as in the patient we just presented, and patients who have silicone stents that either need to be placed or removed. Preoperative evaluation, I'm not going to spend a lot of time on the preoperative evaluation, and this is because it's going to be done in another upcoming webinar that the AABIP are going to do. However, I do want to highlight that both the bronchoscopist and the anesthesiologist need to go through the checklist of a preoperative evaluation assessment with the patient, and together need to discuss that all of these things have been addressed. The main things specifically are symptoms that patients are coming in, what's the neck exam like, what's the size of the lesion, the tumor, its location, and of course other comorbidities that may be getting in the way that you need to be aware of. Now this is the setup of what our setup looks like in the bronch suite. This is obviously either done in the OR and the bronch suite, and it needs to be included in the discussion with your nursing staff, or whether it's your RT staff that's going to be helping you prepare for these cases. They need to know exactly what it is that you need and all the equipment that you might need. The equipment needs may vary slightly based on the type of ventilation that you're going to do, and we're going to discuss this a little bit. We do conventional ventilation here at the Cleveland Clinic. So you can see on this list we've added Acrylics is on there and caps. In fact, we have a Portex adapter plug that we rip off of the bronch swivel adapter that we also use as part of our setup to plug up some of these caps that we use. We happen to lose that, then we'll use one of these Blue Man plugs that we can use, but we have a lot of caps that we need and Acrylics for a closed system, and Basem's going to discuss that a little bit more in detail, the differences between the two types of ventilation. With regards to technique itself, you know that there's the classic intubation you're all familiar with. You can go alongside an endotracheal tube. There could be direct laryngoscopy aided, or you could go through the stoma itself, the tracheal stoma itself if you need to. From my end, when I need to do rigid bronch, the first thing I'm going to do is place the patient in the supine position. I'm going to remove any false teeth that might be there. I'm going to move the patient to the head of the bed. Some bronchoscopists allow the patient's head to extend beyond the end of the table. And once I pull the patient to the head of the bed, I'm going to put a shoulder roll to help bring the trachea into a more anterior position. This can either be done with various foam pads that you might have, In our suite, we actually just take a sheet and we roll it up to help us accomplish this, to get a shoulder roll. After that, we're going to put a tooth guard in place or a piece of gauze to protect the upper gums. And then the patient's going to be positioned with extension of the neck, allowing for alignment of the pharynx, larynx, and trachea before the scope go in. So while I'm doing all of this and setting up everything, Basem, what's going on from your end?
Well, thanks, Sonali. You gave me already great information about the clinical situation of the patient, the stridor, you mentioned that. You mentioned also that SVC syndrome and the fact that the tumor is large, compressing the trachea. So I always like to review the CAT scan myself, not just the report, but the actual images. I encourage all our residents to do that themselves as well. So in this case, you have seen the tumor is compressing almost all of the trachea. So there's a simple classification system out there. If the tumor is not affecting the diameter of the trachea, that's class 1 or mild. Moderate is less than 50% stenosis of the trachea, and more than 50% would be severe, which is the case we have at hand here. The concern with that, usually the mild and moderate cases, there's not a whole lot of changes in what we do traditionally, but for the severe one is the one that we're concerned about, complete airway obstruction. The classification, what we have seen happening is that once we use muscle relaxation, the tumor with gravity collapses and blocks the whole airway, even though if there's an endotracheal tube in place, sometimes we end up having complete obstruction. We're going to show you the next couple of slides, a couple of pictures on that. So here's a report that we published a few years ago regarding a technique that we have used successfully in managing anterior mediastinal mass. We're going to talk about that in a little bit. But for now, let's talk about the airway itself. So anterior mediastinal mass is a lower airway problem, meaning it affects the trachea. Is it a difficult airway, which what we call difficult airway, meaning upper airway? Not necessarily so. So if the chances or the instance of difficult upper airway, meaning difficulty with mask ventilation or difficulty putting a supraglottic airway in or LMA, that direct laryngoscopy intubation or video laryngoscopy intubation or even tracheostomy, those are the different types of upper airway. The chances of having them in a mediastinal mass patient is nothing more than the average population. However, in this case, we have SVC syndrome. SVC syndrome caused a couple of things for us that we're worried about. First, it decreased the venous return through impingement of the right atrium and the SVC, so decrease the blood pressure, decrease stroke volume, and decrease the blood pressure. Second, it gets in the way of the venous drainage of the face and the neck, and that will result in swelling. And many of you have seen that before. The face looks swollen, and that swelling and the edema also happens in the mucosa of the airway. So having SVC syndrome transforms the issue from a lower airway problem into an upper airway problem. And as you can see, here are some other things that we'll look at to identify upper airway difficulty, like melanoperitstatus and size of the tongue and the neck, as well as the thermomental distance and the obstructive sleep apnea issues. So now let's go back to the issue with the obstruction. As you see in this case, the mediastinal mass of this size could result in obstruction. As you see here, this an endotracheal tube being compressed and flattened. Even though it's plastic, because it's a small diameter, it takes a lot of force to flatten an endotracheal tube. It tells you how much force this mediastinal mass could exert on this patient. As you can see in this one here, we have a jaguar in there because we deemed this particular case unsafe to remove the endotracheal tube and put in rigid bronchoscopy to insert a silicone stent. So the pulmonologist decided to go ahead and proceed with metallic stent to see if they can open up the airway a little bit. Here is a same case after putting the rigid bronchoscope in another time, and you could see the collapse and complete closure of the airway. So how do we handle these cases? Let's go back up to the case that we have published here, and we'll show you that in this case, the prescribed technique or the best technique is to maintain the spontaneous ventilation as we do the induction. So we do whatever technique we like to use, like sometimes use Versed and fentanyl sedation and topicalization. In this case, we use dexamethasone sedation. Dexmedetomidine does not inhibit the respiratory drive and maintain a spontaneous ventilation, even if it used at higher levels that may produce general anesthesia as well. That's why we decided to use it in this case and many others. So we start with a small dose, sedation dose, and some topicalization, secure the airway with the endotracheal tube, and we end up deepening the anesthetic using dexmedetomidine on off-label doses to induce general anesthesia. We added a small dose of vapor anesthetic to ensure amnesia, as dexmedetomidine does not ensure 100% amnesia for this patient. Once we deepen the patient to that degree, evidenced by the responses we see as well as the BIS monitoring that we did for this case, patient got into a state where it was possible to replace the endotracheal tube with a rigid bronchoscopy. Oftentimes we do a trial of pulse pressure ventilation. If that proves successful, then we'll go ahead and paralyze the patient. Then we insert the rigid bronchoscope. It's much easier to insert that rigid bronchoscope with muscle relaxant on board versus without. The ventilation, it's an area of controversy. Many centers use jet ventilation when we do rigid bronchoscopy. However, in our center and a couple of others, we use conventional ventilation. There is no current data to show superiority of one technique over the other. The use of it depends on the case, the local expertise, the resources available, risk-benefit analysis. We believe that conventional ventilation is a superior technique as it's readily available. It's the same circuit we have used for induction, the same circuit we use all the time. Every provider is familiar with it. Sometimes I end up supervising residents or nurse anesthetists who have not practiced in this area before. They do not need additional training for that. They're all familiar with the use of the usual circuit. It has proved to be safe and, again, low cost. We don't add any additional equipment and resources. And we can control the FiO2 if we need to be, if laser is being used or electrocautery. We can easily use the machine to control the FiO2. Jet ventilation is being used in other areas. It requires a special equipment. We're going to go over some of the equipment used for jet ventilation in a little bit. And also it carries with it the risks of jet ventilation in case of power trauma. And FiO2 can only be controlled if we're using the automated jet ventilation, so-called monsoon, which is about $35,000 to $45,000 cost, and add another equipment to the operating room. In this slide in front of you, you could see the rigid bronchoscope in place, connected to the circuit on the ventilating side port. And we do manual, as you could see in the right upper panel. We do manual ventilation using the anesthesia bag, and we control the FiO2 the way we like it. We try to keep high flows to maintain that bag full, but for that particular use, we need to have a closed circuit. So all the leaks around the bronchoscope are, as Dr. Sethi can explain to us how they accomplish that goal for us.
So once I get the rigid in place, in order to get a closed system, I take Krelix. So what I usually do is we soak it in saline and then gently pack the mouth, making sure not to cut or scrape anywhere in the back of the mouth. So you're gently pushing Krelix down. And what I'm doing at that time is I'm actually looking at the anesthesia CO2 monitor, as you can see in that bottom right-hand corner, to see when I start to get CO2 return as well as chest rise. So Basem, while I'm doing this and I'm packing the mouth, what are you doing from your side?
I look at a couple of things. I look at the chest rise as we do ventilate the patient. I also look at the return of the CO2 there, see if there's any evidence of return volume, and also the fact that the filling of the bag. Usually when there's a return of the tidal volume, the bag fills up easily, and we're able to effectively ventilate for that patient. Now, the CO2 wave that we see is not very accurate. We know that there is still some leaks in the circuit, but it just gives us indication that we're getting some of the volume back, and also seeing the chest rise confirm that we're doing effective ventilation. Again, we use very high flows to achieve that ventilation. And we have to use those caps that Sonali mentioned earlier to block all the holes that are not being in use. Jet ventilation, I wanted to go over that review a little bit. You see in the middle panel there's the manual jet ventilator. In the left panel, there's the automated jet ventilator, so-called Monsoon. That has the advantage of being automated and give you a chance to control the FiO2. There's actually a laser button there that you can push and give you 30% FiO2. I personally, if I'm going to jet ventilate, I prefer to use the manual system. It connects me to the patient with every breath. As I'm pushing it in and I see the chest rise and the chest collapse, it works. In addition to the what we are known for in anesthesiology as being very vigilant, that adds to it and makes me connected to the patient with every breath that we deliver. In the right bottom corner, you see this is the adapter that we use that hook up to the same ventilating port that we showed earlier for the conventional ventilation, and that hooks up to either the manual or the automated jet to be able to jet through the rigid bronchoscope. Tidal volume in jet ventilation depends on many factors. The most important factor is the driving pressure. How much pressure are we using? And as you all know, the maximum pressure we can use in operating room is 50 psi, which is the highest pressure that comes to the oxygen tubing. Inspiratory time is also a factor, as well as airway patency, chest wall, and lung compliance. Another reason why muscle relaxant should be used in these cases. Just to complete the topic of jet ventilation, something some of you may use when you do a suspension laryngoscopy. One of our colleagues here, Dr. Machuzek, sometimes use that technique. It was suspension laryngoscopy. When you do some of these cases, you could do supraglottic jet ventilation, where you hook up the jet needle to the eyepiece of the direct laryngoscopy. Subglottic jetting is using this special catheter to the bottom, called Hansaker catheter, where we attach it to the jet ventilator, like the Monsoon, for example, in this case, or also manual, and it goes below the vocal cords. There's a green basket there that maintains the end of the catheter in the middle of the trachea, avoid webbing with that high pressure we push through, and that's also for cases of suspension laryngoscopy and similar cases. In either case, the jet ventilation rule, the golden rule that we all have to remember is that what goes in must come out. So if there's a tidal volume going in, there's a chest rise, there has to be followed by chest collapse. If the chest rise and does not collapse and deliver another pressure, another tidal volume, then we're causing stacking of breath, and you all know what could happen from that, the barotrauma that everybody talks about and fears of when it comes to jet ventilation. That's why it's very important to monitor the patient extremely closely, and that's why I like the manual jetting system, because I'll be connected to the patient with every jet ventilation. What's new in the jet ventilation? There's this new adapter where it's usually jet ventilation is contraindicated in closed-off airway. That's why when jet ventilation technique is used, you do not pack the mouth, you do not use plugs for the holes of the rigid bronchoscope. You maintain the airway wide open because it depends on the entrained air to get the tidal volume in, and all these holes to get the volume out for exhalation. In airway obstruction or partial airway obstruction, we still, now with the advent of this new innovation, to be able to ventilate the patient with jet ventilation using this device called Ventrain, where when you apply your thumb in the middle panel there, you direct oxygen directly into the lungs. And when you take your thumb off, the oxygen goes straight to the environment, creating negative pressure and actively sucking out all the tidal volume out. So you do active inhalation and exhalation. So you will be able to ventilate using special tubing in airway obstruction. During jet ventilation, it's extremely difficult to monitor CO2 with a traditional technique. It's almost impossible. Therefore, something else, if we're interested in monitoring CO2, to do something different. In this case, I'm showing you here example we have used is the transcutaneous CO2 monitoring. It works well. There are two issues with that. That it requires initial warming time for it to start picking up the signal. Second, there is a lag period between the actual CO2 circulating in the blood and in the subcutaneous tissue, which this monitor measures. So what you see right now is not the current CO2, it's a few minutes ago. It's about 10 minutes or so, but that's available to us. In conclusion, again, jet ventilation is a viable technique to be used with rigid bronchoscopy. But we prefer the conventional, again, because it's available, it's everybody's familiar with it, it's a low cost, we can control the FiO2, there's no need to purchase additional equipment or to add another equipment to the already crowded room with a lot of equipment like C-arm and such, anesthesia machine, all that in that small space that we have. So to be able to accomplish successful anesthetic, there are many options for the case. Inhalation anesthetic obviously is an option of propofol infusion. Some other people use propofol and Remy and such. Of those, my preferred technique would be propofol infusion straight. The use of inhalation anesthetic is not preferred, as we're going to talk later about the advantage of using total intravenous anesthesia. The addition of narcotic infusion like remifentanil or fentanyl is not really called for, since this procedure is not painful. You might see a little bit of tachycardia during insertion, but that's it. It's not sustained tachycardia like we'll see with suspension direct laryngoscopy. But adding narcotics, powerful narcotics like remifentanil, for example, will cause hypotension, will cause bradycardia. And notice I'm not saying can cause it, it will cause, because you will see that almost in every single case. Then you end up giving fluid that you could have done without, or you end up giving vasopressor that you could have done without. It just complicates the anesthetic, add things that patient could have done, could have avoided, and avoid the whatever risks that comes with it. Midazolam and fentanyl are always helpful. Midazolam gives the better experience, and fentanyl help with the post-op coughing a little bit. Ketamine, even though it's bronchodilator and does not suppress breathing, if you want to maintain a spontaneous ventilation, it is known for causing increased secretions in the airway and also post-op delirium that many patients have complained about. We already discussed dexmedetomidine, and phosphorus is not currently available. So total intravenous anesthesia is the preferred technique, as you are able to reliably provide anesthetic to the patient, avoid polluting the room with inhaled anesthetic. And what happens from that is that patient, if you use just inhalation anesthetic, your patient end up being awake, not getting enough anesthesia, and because of all of us inhaling the anesthetic from the circuit leaks, as you could see in this picture, the pulmonologist is asleep and the patient might be awake. Not a good combination, as you could imagine. So we like to use SEVA. It ensures the continuous delivery, allow utilization of intermittent apnea or jet ventilation or techniques like that to maintain the anesthetic and make sure the patient amnestic throughout the whole thing. Muscle relaxation is recommended. It's much easier to insert rigid bronchoscopy, rigid bronchoscope with muscle relaxation on board. It improves overall lung compliance if you're using jet ventilation or manual ventilation, provides a motionless patient, and very helpful altogether. Fluid management, we try to minimize the amount of fluid we give the least possible, but it's just barely adequate for the patient. Try to keep them on a little bit on the dry side. Some of these patients you might, as you are familiar with, have a long-standing pulmonary disease, may have core pulmonale. They don't handle the fluid much. And also, if you have any additional fluid that may cause a pulmonary edema, may make the recovery not as smooth or as pleasant as we like it to be. We try to use 100% FiO2 during the whole procedure in anticipation of some interrupted ventilation, and because of the nature of the operation, or because of also the leaks that could happen, you may not be able to effectively ventilating the patient. So you have a cushion for maintaining the saturation while you're not able to ventilate. However, when the plan is to use YAG laser or electrocautery and such, we try to lower the FiO2 to less than 40%, ideally about 30 or 35%. And again, when we do that, please allow a couple of minutes for equalization. It's not as soon as you lower your FiO2, you go ahead and laser or such, because it takes a few breaths to achieve that end tidal FiO2 of the desired 35% and avoid having airway fire. When the patient cannot tolerate the hypoxemia, or if you're using the rigid bronchoscope and ventilation is not feasible, what we end up doing is that we hold the case for a few seconds to deliver a few full tidal volume 100% FiO2 breath in intermittent apnea, as you could see in this case here, where the pulmonologist is trying to reach the subglottic area from above with a rigid bronchoscope and from below with a dilator and a wire, trying to achieve continuity of the airway to allow this patient to have voice again. This patient is post-motor vehicle accident trauma, had a tracheostomy for about 6 months or so, resulted in complete fibrosis above the tracheostomy level and separation of the trachea from the larynx, and thus he was not able to speak. With the establishing of that connection, she was able to talk later on. While working from above and below made it difficult to ventilate while they are working, so we end up using intermittent apnea technique. In these cases, because of the expected trauma from rigid bronchoscopy, as well as the potential swelling, we like to use steroids. Also, steroids are known in anesthesia to have a post-op nausea and vomiting prophylactic effect. The dose for nausea and vomiting is usually about 4 to 8 milligrams. In this case, I end up using a little bit more than that, about 10 milligram IV. I give it early on in the case. We also know from a small study that steroids can give a better recovery profile to prevent some of the known as and this talked about phenomena called post-op fatigue phenomena. I hope this review was helpful to you, and now we're going to go over a few other scenarios to discuss different cases with special considerations.
Thanks, Basem. So let's go over another case that we had together. I think you remember this case. This was a 56-year-old male former smoker who had a history of an esophageal adenocarcinoma in 2014, got neoadjuvant chemo-rads, had an esophagectomy with a pull-through, and then unfortunately had a recurrence again in August of 2017, again got some chemo-rads, and now at the end of last year was admitted with progressive dysphagia and was coughing up some bile. GI saw the patient and they did an EGD. They saw there was an ulcerated mass in the gastric pull-through that was consistent with the recurrence, and they saw that there was a bronchoesophageal fistula there. Unfortunately, they were unable to clip or stent the fistula because of the prior surgery. They were unable to stent that area, and when they tried to clip, it was so fibrotic, they couldn't get anything to sit in that area, and so they called to see if there was anything that we could do. On CAT scan imaging, you can see here, there's a pretty decent-sized fistula you can see here through the left main stem between the bronchus and the esophagus there. Lower down cuts, and as we go down, the left main stem then looks okay. And bronchoscopically, when we went in, this is the main carina here, and you can see the fistula sitting right at the main carina, and when you get up a little bit closer, in fact, you can even see the nasogastric tube there sitting on the gastric side, and there was bile actively coming through this fistula. So, Basem, from your standpoint, I know what I need to do. I need to get this fistula covered by putting in some kind of wide stent, doing a rigid bronch. But from your standpoint, what are your concerns going on?
The major concern for these cases is the aspiration. This case actually has two aspects that we need to pay attention to. First is the stomach pull-through. Those patients, if you talk to them, they will tell you that they do not sleep flat ever. For their life, after they have the surgery, they always sleep sitting up, either in the recliner or a special bed that keep them up, because as soon as you go a little bit lower or flat, gastric content keeps pouring into the lungs. In this case, we have also recurrent, and we have a TA fistula, so that's a guaranteed aspiration regardless what position they are in. And oftentimes we see the TA fistula by itself from the gastric tumor without the stomach the gastric pull through, but in this case we have seen both of them. So generally speaking, whenever we see stomach pull through, we try to do awake intubation for aspiration prophylaxis. We do sedation, topicalization, do the tube in, and avoid having, once we secure the airway, then we go ahead and put them flat and proceed with the flexible bronchoscopy procedure. So that's a luxury that we do not have in this case, since you're planning on putting in a silicone stent and you want to do a rigid bronchoscopy. So in this case, we do our best. We can give antacid before we start. We can give H2 blockers. I'm going to count and depend on Sonali in suctioning every stomach content that she sees in front of her as she does that. And also, when we do ventilation, we either do spontaneous ventilation, or if we do positive pressure ventilation, we have got to use the lowest pressure possible to do that, because the higher the pressure, the more escape of the tidal volume into the stomach or the leftover from the bowel and cause distension of that, and that would result in more gastric content and intestinal content getting into the airway and more aspiration. So it is a difficult, tough situation, regardless how you dissect it, but we all have to do what we can to get this patient done and taken care of and close that fistula.
So this patient did fairly well. We were able to do all that and get a Y stent in to cover over. Unfortunately, we couldn't get a metal stent in that because of the location of where it is. It's so close to the main carina, but as you can see here, the fistula is closed over nicely. We took the limb of the left main stem all the way down, and you can see here the left upper lobe and left lower lobe. And we were able to give the patient a couple months where he could have some decent quality of life before he passed away more recently from this. So Basem, what I want to do with you now is I'm going to go through a rapid fire. These are kind of cases that I think have kept us up at night, that have given both of us palpitations and made us very nervous in the Bronx suite. But just to give some words of wisdom, if these kind of cases show up in people's ORs or hospitals. So I think you remember this case. This is kind of that anterior mediastinal mass case that we were discussing at the beginning, but now let's throw in pregnancy. So 30-year-old female, 33 weeks pregnant, has an impending SVC syndrome, this large anterior mediastinal mass, who's short of breath, cough, and has an inability to lay flat. She kind of looked okay sitting still, however, she could not lay flat. So what are your words of advice in a situation like this?
So we have the same consideration we had for anterior mediastinal mass as we talked about, and in this case, it is of the severe form. It's more than 50% obstruction of the airway. We also have the issue with the upper airway from the SVC syndrome being swollen. But after that, the changes of pregnancy. So now there are some more into the story. So with pregnancy, there is edema of the upper airway, and even patients who are easy upper airway before pregnancy, they become difficult just from the edema of the upper airway and the vocal cords, and there's higher chance of failed intubation in that population. Also, the respiratory changes add to the challenges that we see. The increased amount of ventilation, increased respiratory rate, increased tidal volume will result in alkalosis, and also the fact that of the distended belly decrease their FRC, and they are prone to faster desaturation, if you will, when you stop ventilation. Add to that, we already talked about the cardiovascular effects of mediastinal masses, especially when they push from cardiac chambers and right atrium and SVC, decreasing the venous return and the blood pressure. In pregnancy, the gravid uterus, if the patient lies flat, would push in the IVC and the aorta, so-called aortocaval compression, and that would result in 20% drop in the blood pressure. So in patients who are more than 12 weeks pregnant, we do something called left uterine displacement, where we add a roll on the under the right side of their trunk. That would kind of shift the uterus to the left a little bit, take it off the IVC and the aorta, and that would not result in drop in the blood pressure. Add to all that the gastrointestinal changes is decreased sphincter tone, lower esophageal sphincter tone, increased gastric acidity, and it is claimed that there's increased risk of aspiration after 16 weeks pregnant. So in this kind of case, we want to observe all the issues that we talked about with mediastinal mass, add with the issues with pregnancy. We give H2 blockers and tacids by straight orally to decrease the gastric acidity. We'll make sure they're fasting if there is time, if it's not of emergent nature. And we try to follow the ACOG, the American College of Obstetrician and Gynecologists recommendation for managing pregnant ladies. And I just wanted to let folks know that from our end, anesthetic-wise, there is no known concerns with any anesthetic that we use on the mother or the fetus. So we use those inhalation anesthetic or IV anesthetic, whatever we need according to the case. When we do the left uterine displacement, we could use the fetal heart rate to get to the best possible position where we avoid the aortocaval compression. Again, the pregnant woman should never be denied indicated surgery regardless of the trimester. However, if something is elective, we should wait till the baby is out after full term. If something kind of urgent or not that can wait, and there's a chance we can wait till the second trimester, that would be preferred, because the first trimester is the organogenesis period. We'd like the baby to have the best chance at that time. And there are some thought that some anesthesia during the first trimester may result in miscarriage and so forth. So we try to avoid that. And let's hear what happened in this case from Sonali.
Yeah, sure. So because she looked okay sitting still, but couldn't lay flat, the first decision was, where were we going to do this case? Was this safer to do in the OR? Was this safer to do in the bronch suite? And the decision was made that because the airway was a major issue here, we felt, and everyone felt, a lot safer for this patient to be brought in the bronch suite so that we had all of the equipment that we possibly could need if the airway became a problem, instead of trying to anticipate everything and taking it to an OR. So she first had an epidural placed, and because she looked like she could tolerate being semi-upright at a 15 to 20 degree angle, the OB team decided that they could do a C-section in this position, and then that was the position that they were going to deliver the baby in. In anticipation of this, both groins were prepped for the possibility of ECMO. So we did have thoracic surgery there on backup as well as the OB and the neonatal team. They did deliver the baby first. This was a picture of the baby that was delivered in the bronch suite. After that, she did get into a little bit of distress, and LMA was placed, and it actually sat reasonably well, and she ventilated fine with the LMA, so it was decided to keep that airway in place, and EBUS was done at this time, and this actually turned out to be a strep abscess, and a stent did not need to be placed. So rigid was on backup, but never actually had to get used in this situation. 5 days later, she actually did have a pericardial effusion, which resulted in a window, and at that time she had a mediastinoscopy done, and they did drainage and decompression of the abscess, and she's at home now with her baby.
What I wanted also to mention for the pregnancy is that if we take care of a patient that has a pre-viable fetus, for monitoring of the baby, so we could do the heart rate monitoring before and after the procedure. That's adequate. As for the viable fetus, the recommendation is to do intraoperative fetal heart rate monitoring and contracture monitoring, and if there are deceleration, that would be used to decide whether C-section needs to be done or not. And in that case, trained obstetrician should be available to proceed if needed. Therefore, these cases are recommended to be done for viable fetus only in hospitals that have privileges for delivering babies.
Okay, moving on. So another case. So let's do foreign body removal. So this was actually a great case. This is one of my favorite stories. So during a drug exchange, there was this guy that was out who had making a drug exchange of crack cocaine, and the cops happened to be there, and they grabbed the guy, who then somehow got away, and he started to run. And as he was running, he shoved the bag of crack cocaine in his mouth, trying to swallow it. Unfortunately, he aspirated it and suddenly dropped to the ground and arrested because he lost his airway. So EMS arrived at that time. They were able to intubate him. He developed a pneumothorax during the chest compressions and was transferred to the Cleveland Clinic. And when he got up to the ICU, they were having trouble ventilating him in the ICU, at which time we were called to the bedside. He had a 7.5 ET tube in, and when the flexible bronchoscope was put in, it was seen that the bag of crack was sitting in the trachea, and what was happening is it was sliding up and down the trachea. So when compressions were being done, it would kind of come up the trachea, and they were able to ventilate. And then when you would stop doing compressions, it would get stuck in the distal trachea. We tried to pull this out, but the ET tube was too small to be able to get the bag out. And the only choice we had was to rupture the bag, because we couldn't get it down the left main stem or right main stem, but to rupture the bag and then get all the rocks go down one side so that we could at least ventilate them to get them down to the bronch suite. So using a Fogarty, the bag was ruptured to secure the airway, and all the stones were shoved down the right main stem. And at that point, we brought the patient down for a rigid bronch to start to pull the stones out in the bronch suite. So Basem, when we showed up in the bronch suite, from your standpoint, what were the concerns going on?
Many concerns. I worried about ability to ventilate and if we're going to sustain that. And also looking at the situation here, the cocaine part. Cocaine is known to be a very, very powerful vasoconstrictor. And it depends on how much of it gets absorbed in the body. We might end up seeing a lot of hemodynamic change as well. So I'm just not worried only about the oxygenation and ventilation. As we're working together, you clear as much as you can out of the airway, allow us better chance to ventilate and oxygenate, but also worried about the after effects of absorption of cocaine. Luckily, the acidity in the airway is not of optimal acidity for absorption of cocaine, but if some of it has gone to the GI tract, then that might be some absorption there from the stomach, and we end up seeing the impact on the vitals in terms of tachycardia, hypertension, and even ischemia, because in healthy young adults who never had coronary disease, cocaine is known to cause severe vasoconstriction of the coronary circulation and cardiac ischemia. So these are things that we watch for. And if we see tachycardia and hypertension, the first thing to treat is the hypertension with nitroglycerin as well as nitroprusside as needed. And then we treat the tachycardia with beta blocker. Treating the tachycardia first may throw the heart into failure as you kind of suppress the heart against unopposed alpha. But if you take care of the blood pressure first and then you get down the heart rate, the patient will do well.
So in this case, we were able to remove all the rocks from the lung through rigid bronchoscope. And then we took the flexible scope and we were looking to see how much of it was ingested to see if GI needed to come in to remove from the GI tract because of the absorption issue. And we actually found a $20 bill that he had while he was trying to swallow all of this and pulled that out of his stomach. And GI actually came in and removed rocks from the stomach. And he actually was discharged home 48 hours later. So interestingly, the cops didn't think he was going to make it, and they actually left. And so he actually got to go home, and then when they found out he was alive, they had to go to his house to arrest him, to put him in jail. So how about, Basem, when we have patients with refractory hypoxemia? We get a lot of these patients that come in. For instance, we had this 65-year-old female smoker. She had metastatic anal cancer. She already is short of breath. She's 85% on 6 liters nasal cannula. I need to put a rigid bronchoscope in here. Ideally, I would like to do some argon or laser if that can happen, but her stats keep dropping. So what can we do together here?
For airway obstruction and wheezing and not ability to ventilate, for those reasons, we end up starting the case while the patient is spontaneous to decrease their anxiety and decrease the work of breathing. We offer them a Heliox, 30% oxygen and 70% helium. That works much better. Their stridor goes away. They start breathing more comfortably. They look more relaxed, and the work of breathing goes down. That's during the spontaneous ventilation phase. But after we induce anesthesia, we can ventilate them with positive pressure ventilation. And in this case, when we use 100% FiO2 to be able to maintain oxygenation. As you do lasering of this lesion here, most folks would think that we have to lower the FiO2 to less than 40%, maybe 30 or 35% to avoid airway fire. But we have to think about it in a different way. For air fire to take place, we have to have three things available at the same time, at the same spot. Oxidizer, which is either oxygen or nitrous oxide, fuel, which is something to catch on fire, generally like a PVC tube or such, and then the energy source, which is laser or electrocautery. In this case, if you're going with a rigid bronchoscope and you're lasering through it, there is no plastic or PVC that would catch on fire, and you are lasering a distal lesion in the soft tissue. So if you have 100% to maintain the oxygenation to avoid the refractory hypoxemia, as I mentioned, using laser, it would be safe and doable, and patient will not have an airway fire, and that would be a better way to manage that versus lowering the FiO2 and having the hypoxemia that we're worried about.
Great. So this is also a patient we have. Is occasionally you might have patients with relapsing polychondritis. As you know, they've got no anterior rings. They've actually got no rings or support or cartilage support of their airways. So everything, bronchus and the trachea are all malacic, and then we even stenting them, the airway, they barely stay up, and the CO2 and the wake up becomes an issue for these patients. So if you could give us a brief idea on how to manage patients who might have high CO2 during the case or may have difficulty waking up.
We have to have a plan ahead of time. We know exactly what your steps are going to be and how we're going to manage the airway during the whole process. And we figured out a way to maintain positive pressure ventilation to tend to open the airway with the positive pressure that we are applying. In this case, he had a T-tube, so we end up putting an LMA from above our supraglottic airway, and then we also attach the tube connector to the T-piece. So if you're working from above with the bronchoscope, we ventilate through the T-piece. If you are working through the T-piece, then we ventilate from above with supraglottic airway, and thus maintain positive pressure ventilation and opening the airway with such pressure to maintain ventilation. The challenge comes at the end as we're trying to get the patient back spontaneous. Yes, you have placed some stents to maintain most of the airway open, but the areas that does not have a stent continue to collapse, and we end up seeing skyrocket numbers of CO2. I've seen it as high as 220, and in this case, we end up bridging the patient from the sleep state through the semi-awake into very awake state with the use of BiPAP machine to stent the airway open with that pressure to maintain ventilation and oxygenation and reasonable CO2. Remember, these patients live at relatively higher CO2 than average, and we have to accept that level.
In the last case, Basem, so this is a stent that's in a patient. We have a lot of these customized stents we have to, that we put into our patients, and when it needs to be revised or pulled out, clearly this is a stent that I'm not able to pull out through the rigid scope itself, so I need to grab it with forceps and pull everything out en bloc. So how do we manage when I go in, grab a stent, we pull everything out? What do we do at that point?
The collaboration and communication between us helps here greatly. We have to know when you're about to do that. So before you do that, we optimize everything, the tidal volume, the FiO2, and on all that to allow us an apneic oxygenation period. And as you pull that out and you pull the rigid bronchoscope out, I am prepared with the whatever helps me to maintain that ventilation. So if mask ventilation was successful with this patient, that's what we're going to start with. If you're going to be a longer period before you go back in and insert the rigid scope to put in the new stent, then we'll go ahead and insert a supraglottic airway. If that proves to be successful before we start the rigid bronchoscopy, And if not, we'll go ahead and also put in endotracheal tube to maintain that. So it all depends on the timing of doing it, being prepared with alternatives to maintain that oxygenation and ventilation, and that would result in a safe outcome.
So in summary, I hope everyone understands that if you're doing rigid bronchoscopy, of course, most of these patients are obviously coming in, they're high risk, and there needs to be flexibility between both the anesthesiologist and the bronchoscopist. There has to be this understanding of concept of what it means to share the airway and talking through each of these cases and doing them together. If there's one quote, I think the two of us, we put this together thinking what's the big takeaway point that we would have you guys go home with. It's the key to favorable outcomes lies in a deep understanding of the underlying lung disorder. There's got to be open two-way communications between both the anesthesiologist and the pulmonologist. Both of you have to understand the nature of the procedure, and above all, there's got to be vigilance, and you have to be prepared for anything that can go wrong in these cases. With that, I'd like to thank you guys, and if there's any questions anybody has.
Thank you all for listening, and I'll happy to take any questions that you might have.
Awesome. Thank you very much, Dr. Abdelmalak, for really a detailed and comprehensive review of a complex facet of the management of these difficult airway cases. I loved your presentation. I thought it did a great job in demonstrating and underscoring the importance of the pulmonologist-anesthesiologist relationship and the team effort required in optimizing the chances for the best possible outcome in these tough cases. So while we wait a couple questions from the audience, drawing from this theme, I'll get the questions rolling. And my question really is for both of you. For those pulmonologists in the audience and who will be listening to this webinar in the future, who are just establishing an interventional service utilizing the operating room, how do you recommend they approach their anesthesia colleagues to discuss, and these may be colleagues that do not have experience or a lot of exposure in managing these airway cases. How do you recommend they approach them to discuss the process, the organization, and the mutual understanding of these goals? Do you recommend a joint protocolization, formation of a core anesthesia team, perhaps a mutual lecture series and simulation training, perhaps input from experienced centers like yourself, or maybe a combination of the above? I'm just curious how you all got started and what your thoughts are on that.
Sure. I was lucky when I came to the Cleveland Clinic. Obviously, I had Dr. Gilday and Machuzak here who had worked on putting together an amazing program and had already gotten anesthesia on board. But I have been in the situation at two prior jobs to this where I was not in that situation and I was building a program. And so what I had to do was you first have to get confidence built with the anesthesia team that you know what you're doing, that you're competent at what you're doing, and that comes with time. So it started with me starting with simpler cases like doing EVIS and NAB bronch, maybe the more diagnostic stuff, and taking that to the OR. I didn't have the capability of doing this in the Bronx suite, and finding one staff anesthesiologist who could be the go-to person who I thought was enthusiastic to want to work with me on this. So I first identified who that one person was. I spoke with them and said, is this something that you're willing to work with me on to build a program? I got the support of my own section head as well as the anesthesia section head. And then we started by going into the OR and then doing cases that were simple so that the entire team got very comfortable that we were competent in being able to do this. I think if I had gone in with one of these anterior mediastinal masses right away and then there was some complication and the patient had died, that probably would have been the end of the program right there. It did take a lot of time, but slowly we built it, and then we took on more and more complicated cases, and then it started to work well. And then more anesthesia attendings became interested in this, and then another one came on board, and then they started coming to tumor board into multidisciplinary forums to see that these things actually did matter or make a difference. So Basem, I don't know if you could speak to how the program started here.
Yeah, we started doing cases together, and we end up doing more and more. As we do more and more, we talk about the case first before we do it, and then we develop the understanding and having the plan, and then executing it. As we did more cases together, we developed that trust and the friendship that we had, and the buy-in from all members of the team, realizing that every team member, nurses, therapists, as pulmonologists, anesthesiologists, all are important, well as residents and CRNAs, and everybody in the team is important to the success of the team. We work together as a unit, and we deliver the plan that we have discussed ahead of time. As far as starting new places, what we have done our part, myself and other anesthesiologists who are specialized in this area, like Dr. Mona Sarkis and others, we give talks at national meetings. We have many publications out there that highlight some of the techniques and that we use, as well as the seminars and workshops that we do. And many of us have traveled around the country and we're talking about this to share our experiences that we have developed over the years with our colleagues in other hospitals, help them out. And I personally get a lot of calls and emails from colleagues who want to start new services, and we help them out with some of the tips on how to do it safely.
Those are great tips. And for those of you who can't see, Dr. Carla Lamb from Leahy Clinic also has some recommendations down there in the chat box. It looks like they have a fairly integrated relationship with their anesthesia team, and with frequent conferences and other simulations and such. So these are excellent tips. I think we have time for one more question. I'm just going to take this last one, and then we'll be out of time. It says, with jet ventilation, we're unable to monitor FiO2. How long do you have to wait until using ablative therapy, or is it just kind of a feel thing?
With jet ventilation, usually use 100% FiO2. Again, you do not worry about the FiO2 or the risk of fire unless you have something in the airway. So if you are lasering beyond the endotracheal tube, if you have endotracheal tube, or beyond the supraglottic airway, or through a rigid bronchoscope, once you do not have a plastic or something catching fire in front of the laser, then the FiO2 here, it does not matter much. If you're worried about that and there's a chance that you might do that, then what we do that, and even if we don't worry much about the fire when we do not have fuel in the airway, we still go the extra mile and lower the FiO2. So using the monsoon jet ventilator, you can lower the FiO2 using 30% the laser button, and you just wait a few breaths, and that would usually result in lowering the FiO2. So as far as the manual jetting, controlling the FiO2 is hard because you do not know how much of the entrained air is going in with the tidal volume. As much as 50% or even more of the tidal volume is from the entrained room air, which is 21%, add with the influx from the oxygen, 100%. So you may end up getting somewhere around 60% or so, or 50% with that combination. So that, as far as the FiO2 was jet ventilation. I hope that was helpful to you.
Great. Thank you, both of you again, just really for an awesome talk. I really love the format. I think everyone appreciates as well. I think we're out of time. Before we formally close the session, I want to turn the mic back over to Dr. Shah for our final announcements. Dave?
Great, and thank you so much. I would echo everything that Ara had mentioned. I think this is a great demonstration of the teamwork and collaboration that we have to have as IP physicians with our anesthesia colleagues to communicate effectively and appropriately with our about some of these complex cases. As you can see on the screen here, I want to point your attention to all of us that work with anesthesiologists or advanced practice providers. In the AABIP, we do have professional chapters that aside from having a common ground of interventional pulmonary, also we want to invite our anesthesia colleagues and APPs to join the AABIP. We do have chapters and we have the contact information on the screen that you can have your colleagues contact them to find out how to get plugged in, or they can contact me directly and we can do that. The second thing is you should now be able to see on your screen the upcoming tentative schedule. As we all know, this is what we're planning, but sometimes we may have some last minute changes. In addition, we had highlighted earlier that we will be moving to a new webinar software platform starting next month. So please allow yourself a few extra minutes when you're logging in to permit yourself to download any necessary software. We will probably be using the Zoom platform. And we also appreciate your patience working with Ara and I as we work out the kinks on that new system. So with that, I'm going to conclude our evening and again, thank our speakers. Thank you everyone for joining us today and have a wonderful rest of your evening.